Good morning, everyone. Today we are going to continue with our radiology club. The science of radiology will be presented by your colleague, Dr. Maysam. May she starts.
Good morning. I want to represent two radiological science about CNS. One of them is reversal sign. Reversal sign mean decreased density of the supratentorial parenchyma with increased density of the brainstem, thalamus, and hypo and cerebellum. White cerebellar sign, as we said, it means diffuse decreased density of the supratentorial brain parenchyma with relatively increased density of the thalami, brainstem, and cerebellum. This sign indicates irreversible brain damage and very poor prognosis. Therefore, all radiologists should be aware of this sign. The causes of this sign, the causes of white cerebellar.
What's this reversal sign?
It means hypodense of the supratentorial parenchyma. Normally reversal sign is normal. يعني white يعني cerebellar sign, cerebellum and thalami and brainstem is white in density. Low in density, while supratentorial is white in density, and this
white, high density.
High density.
It's not white. It's
Okay.
okay. هذا normal. صح؟
Yes. لا أنا إذا ما دس مناظر ما أقدر إلا بالمناظر. أي.
So, اشرح لي بالreverse. What will happen in the reverse?
Supratentorial parenchyma is hypodense, while thalami, brainstem, and cerebellum hyperdense.
Why? Hyperdense. Why? ما عليه تركي presentation. يعني بس تعلموا تقرون وخلاص. Why? You've done it.
Damage of brainstem, damage of the brain parenchyma.
Damage of the brain parenchyma, while preservation of the brainstem.
Yes.
The brainstem is not damaged.
Not damaged.
Only the brain parenchyma is damaged.
But it is irreversible damage of the brain.
Why? Why damage the brain parenchyma? Why it becomes hypodense? Okay, damage ماشي خربت. ليش صارت hypodense?
ischemic attack.
علي يا ريت واحد.
لا ما دافع الله.
Why it becomes hypodense?
Ischemic attack.
What will happen in ischemia?
Hypodense in area that affect.
Okay, why it's hypodense? Why it becomes hypodense?
Yeah, not blood supply not reached in this area.
Okay. Blood supply not reaching the cerebral hemispheres. Okay, they become what?
Hypodensity.
Okay, why become hypodense? What will happen? They will calcify.
Yeah, dead area.
Okay. They will become calcified. There will be hemorrhage مثلا.
No hemorrhage.
Why it becomes hypodense? Pathologically, what will happen when it becomes ischemic? What will happen?
يعني
What will happen? Edema. It will become diffusely edematous. You will lose the gray-white matter differentiation. Okay? They will become all the same size. The ventricles will be compressed by the edema. With the CVA, with the ischemic infarction. When you have MCA infarction, for example, it will become the part that infarct will become edematous but focal. Now here it will become diffused. All the cerebral hemisphere. Why the brainstem and the cerebellum will not be diffused? Edematous also. Why?
Not affected يعني.
Why not affected? ليش البرين was affected والبرين still not affected?
I don't know.
You don't know? No, you know. But you don't know that you know. زين. الإسكيميا it happens because of what?
اسكيميا يعني تراما.
ليش صارت إسكيميا؟ Why there is ischemia in the brain?
decrease blood supply.
Decrease blood supply. منين يجي blood supply للسيربيلم؟ cerebrum. Basic anatomy. Arterial blood supply of the cerebral hemispheres. From where?
Internal coronal artery.
Sorry?
Anterior coronal artery. Internal coronal artery.
Carotid.
دكتور أنا I don't know. No.
You don't know, you know.
لا يعني شوية.
I will kill you if you don't know internal carotid.
لا internal carotid.
Internal carotid artery will give the ACA
anterior and middle
and MCA. Okay. Where does blood supply from the cerebellum and brainstem come from?
posterior cerebral artery.
اللي هو منين؟
basal cerebral artery. Basal cerebral artery from vertebra. Okay.
So there are two different sources of blood supply for the cerebrum and for the cerebellum.
Okay.
So when there is abnormality affecting the internal carotid artery, you will have this reversed sign,
Okay.
which is not really reversed. It's just the brain becoming hypodense. The cerebellum is the same. The brainstem is the same.
Yes.
Get it?
Okay.
So you know it. Don't say I don't know. Okay? Good. Continue.
Cause of this sign, birth asphyxia, drowning, status epilepticus, bacterial meningitis, encephalitis, and post-cardiac arrest.
Okay.
Apraxia.
So when you see this sign, you will tell them what? You say to the clinician,
reversible, يعني reversible.
irreversible brain damage with bad prognosis. Does it mean a brain death? No. It doesn't mean a brain death. It means very poor prognosis. That's it. Okay? Poor. Maybe 1 in 1,000 it will become better. Maybe. But it's not brain death. It's not, brain death is not a radiologic diagnosis. Okay? It's a what diagnosis? And not even a clinical. It's an EEG diagnosis. Yes.
ما أعرف شو
What's wrong? شو الناصر؟ يلا شنو السبب؟ Finished or?
finished. Okay.
You did two slides?
No, one sentence.
Okay. So we can see here what's happening. You can see there is an increased hypodensity affecting the whole cerebral hemispheres bilaterally, except for this part, the cerebellum. It's not reversed بالحقيقة. In fact, the cerebellum is the same density, just the rest of the brain is hypodense. Due to the edema, due to the decreased blood supply, causing ischemia, causing irreversible brain damage. Okay? So they call it reversal sign. Yeah. Okay, no problem. I will present this. So what's this? This is called molar tooth sign. It's like a tooth. Okay? شلون سن مسوس روعة. Okay? So what does it represent? It is the appearance of the superior cerebellar peduncle at the level of the midbrain on the axial CT and MRI image produced by abnormal anterior-posterior orientation of the cerebellar peduncle resembling the roots of the molar tooth, and this indicates something called Joubert syndrome. Okay? The other name of it is cerebellar vermian dysgenesis. Okay? So whenever you see this tooth, the molar tooth, indicates Joubert syndrome. Typical diagnostic. Okay? And thank you very much.
There was another side with edema.
What? نرجع عليه. يلا هاي الإديمة. This one? Pseudo-subarachnoid, exactly. This is also pseudo-subarachnoid hemorrhage. It looks like a subarachnoid hemorrhage, but it's not a subarachnoid hemorrhage. It's edema of the brain due to the irreversible brain damage resulting. So don't be mistaken. There is a subarachnoid hemorrhage. No, it's irreversible brain damage. Okay? تمام. Now Dr. Khanda will present to us what the research. She has a very interesting research, which I would like to see. Okay, just a second. What's going on? Okay, good.
Good morning, everybody. Today I'll talk about intrahepatic mass-forming cholangiocarcinoma and the prognostic factor according to the prognostic factor according to the enhancement pattern of the MRI after contrast injection. First of all, I'd like to talk some notes about the phase of enhancement of the liver, and because the liver is the attenuation is different between the lesion and the normal liver. In non-contrast enhanced CT scan, the liver tumors are usually not visible. Only minority of tumor contain calcification, cystic component, fat, or hemorrhage, and will be detected on non-enhanced CT scan. So IV contrast is needed to increase the conspicuity of the lesion. Conspicuity. A normal parenchyma is supplied by 80% of portal vein and 20% by hepatic artery, so it will enhance in portal venous phase. All liver tumors get 100% of their blood supply from hepatic artery, so when they enhance, it will be in the arterial phase. This difference in blood supply result in different enhancement pattern between liver tumor and normal liver parenchyma in various phases of contrast enhancement.
Why the tumors get their blood supply from the hepatic artery, not portal vein?
Because vascular,
So
they from
80% of the portal vein gives blood supply.
to the liver.
ليش التيومر يتركز 80% وراح ياخذ 20؟
liver from hepatic يعني portal vein, بس tumor will get
Why?
from the hepatic artery.
Okay, I know.
It
Why?
is vascular,
So
يعني high
tumors
high
want
metabolic
oxygen.
oxygen. Yes,
Oxygen in the arterial blood, not in the venous blood.
yes,
So the tumor wants oxygen to grow.
yeah.
Okay, so he will go to wherever there is more oxygen, which is the artery, the hepatic artery, not the portal vein.
Okay.
Okay, good.
The different in blood supply result in different enhancement pattern between the liver tumor and liver parenchyma in various phases. In this example, this is a case of small hepatocellular carcinoma in cirrhotic liver. In non-contrast CT, the tumor is not visible, while visible in portal venous phase. Arterial phase.
It's visible in where?
Not visible in portal venous phase, also in non-contrast CT, but visible in arterial phase.
Arterial phase, okay?
Yes.
Because it wants oxygen,
Yes.
gets blood from the artery.
Yes.
You can see it obviously in the arterial phase, you cannot see it in the non-contrast
Portal
or
or in the
portal venous phase contrast. Okay.
arterial phase imaging, optimal timing and speed of contrast injection are very important for good arterial phase imaging. Hypervascular tumor will enhance optimally at 35 seconds after contrast injection, late arterial phase. This time is needed for the contrast to get from the peripheral vein to the hepatic artery and to diffuse into the liver tumor.
What does it mean to go from the peripheral vein to the hepatic artery? What do you mean by that?
First, the portal vein will enhance,
أول شيء portal vein enhance
يعني venous phase first.
first, okay?
Now arterial phase first. In the first 35 seconds, we have arterial phase. After
What
that,
do you mean by saying the contrast going to go? شلون أرجع؟ There will be more hypervascular tumor or enhanced tumor. The time is needed for contrast to get from peripheral vein to hepatic artery to diffuse into the liver tumor. What do you mean? The contrast goes from a vein to an artery or from artery to a vein?
Yes.
Guys, just wait. She's presenting. I know. When you inject the contrast, you inject it into an artery or a vein?
a vein.
So the time needed for contrast to get from the cannula in the peripheral
Yes.
vein into the where
Artery.
hepatic artery.
Yes.
Okay, so that's what does it mean? And it's the vein, the arterial phase is first, early arterial phase, then late arterial phase, then
Yes.
venous, then portal, then hepatic.
Yes.
Okay, these are all the phases of enhancement. You have to know it. Good.
We have two phases of arterial imaging, one at 18 seconds and the other at 35 seconds.
Good.
In this phase, we see that in arterial phase we see not clearly visible in first 18 seconds, while in the second image it is more clearly seen and
So this is the early arterial phase and the
late arterial phase.
Good.
Timing for scanning is important also, as important as speed of the injection. For arterial phase imaging, the best results are with an injection rate of 5 ml per second. There are two reasons for this better enhancement. At 5 ml per second, there will be more contrast delivered to the liver when we start scanning, and this contrast arrives in a higher concentration.
5 ml per second is a high dose or a normal dose or a low dose?
5 ml normal.
Normal?
Yes.
It's a very high dose. Usually we inject at 2 to 3 ml per second, usually. Okay?
To the liver? For
standard imaging,
Standard.
daily imaging, routine imaging, we do injection at about 2, maybe 3
yes.
milliliter per second. When we do 5, this is like, for example, doing angiography, pulmonary angiography, bolus, big dose. Okay? See the difference between 2.5 and 5 ml? You can
Yes.
see it obviously.
In first image 2.5 ml per second, and in the second 5 ml per second. In first is not clearly visible, while in the second image is shown. In portal venous space, we image the liver.
I'm sorry for the current interruption, but to inject 5 ml per second, what do you must have? What? Two things. First, automated injector. لازم عند الCT يكون ب injector automated حتى يعني ما تقدر, you will not be able to inject by your hand and you calculate 5 ml per second. It's impossible. Okay. Second, you need a big cannula, like a green cannula. The blue or pink will not be enough for 5 ml per second. You need a big one. يعني تحتاج وريد زين.
We image the liver when it is loaded with contrast through the portal vein to detect hypovascular tumor. The best time to start scanning is at about 75 seconds. So this is a late portal venous phase, because enhancement of the portal vein already starts at 35 seconds in the late arterial phase. This hypovascular tumor show seen a hypodense lesion in the late portal venous phase. We have the other phase, equilibrium phase, when contrast is moving away from the liver and the liver starts to decrease in density. This phase begins at about 3 to 4 minutes after contrast injection, and imaging is best done at 10 minutes after the contrast injection. We have a case of small cholangiocarcinoma not visible in the portal venous phase, while it is seen in hyperdense lesion in the delayed phase. Value of equilibrium phase, tumor washout, vascular tumors, retention of contrast in blood pool, hemangioma, retention of contrast in fibrous tissue, capsule around hepatocellular carcinoma.
What does this mean? Tumoral washout, vascular tumors?
And in the delayed phase,
So
when there's
if you see a
washout,
tumor
we have
that washes
vascular.
out in the delayed phase,
This
this
means
must
this
indicate a
vascular
vascular
tumor.
If you see some tumor that retains contrast in the delayed phase, in the equilibrium phase, usually this is a
Hemangioma or
hemangioma, okay? And if you
fibrosis
see the
of
fibrous
the-
scar, the center of it retains
Yes.
contrast, this might be a capsule around the hepatocellular carcinoma or cholangiocarcinoma when fibrous or central fibrous scar in focal nodular hyperplasia.
Yes.
So the delayed phase is also important because it helps us to narrow the differential diagnosis.
Yes. Now we come to our research, intrahepatic mass-forming cholangiocarcinoma in arterial enhancement pattern at MRI and prognosis. Intrahepatic cholangiocarcinoma is the second most common primary liver malignancy, accounting for about 10 to 15% of all primary liver cancer. In abstract, diffuse arterial hyperenhancement of intrahepatic mass-forming cholangiocarcinoma at MRI is associated with better prognosis than is diffuse hypoenhancement or peripheral rim enhancement. In cholangiocarcinoma, we have different pattern of enhancement. Most will present with ring enhancement, or may present with diffuse enhancement or hypoenhancement. But in this research, when there is diffuse enhancement, the prognosis is better.
Diffuse better than hypo.
Yes. To identify whether the arterial enhancement pattern at MRI could predict prognosis after surgical resection of intrahepatic mass-forming cholangiocarcinoma. Material and methods: patient who underwent curative hepatic resection and preoperative MRI for intrahepatic mass-forming cholangiocarcinoma from November 2007 to September 2016 were retrospectively evaluated. MRI enhancement pattern was classified by two radiologists. Recurrence and death data were retrieved until September 31st, 2017. Prognostic factor analysis was performed by using preoperative and postoperative clinical pathological factor as well as imaging finding. Data in 134 patients, median age was 63 years, 87 men and 47 women were evaluated. Median tumor size was 4.5 cm. Arterial phase MRI showed diffuse hypoenhancement in 33 patients, peripheral enhancement in 81 patients, and diffuse hyperenhancement in 20 patients. Cholangiocarcinoma with more than 70% hyperenhancement on MRI had more frequent chronic liver disease, less frequent vascular and necrosis on pathology than did those in diffuse hypoenhancement and peripheral rim enhancement group. The 5-year risk of death in patients with mass-forming intrahepatic cholangiocarcinoma was diffuse hyperenhancement was lower than that of a patient with diffuse hypoenhancement of peripheral limb enhancement, 5.9%, 88.9%, and 59%.
اللي عندهم الهايبر انهانسمنت عاشوا
Preoperatively, yes, but more risk for chronic liver disease.
They have liver abnormality, liver disease,
Yes.
but they live more.
Yes.
Good. Diffuse
rim more.
hyperenhancement, they live more, but they have a liver disease.
Rim enhancement, يعني bad prognosis, they have the risk. In conclusion, the MRI arterial enhancement pattern was a prognostic marker in the preoperative evaluation of patients with resectable intrahepatic mass-forming cholangiocarcinoma. And this is a central MRI patient. The different phases are shown. We have a peripheral rim enhancement in arterial phase, and there is hyper intense lesion. Also, this is hypo intense at the image B. This image shows diffuse hyperenhancement after contrast injection in case of intrahepatic cholangiocarcinoma. Also, this is an example.
What kind of enhancement here? Hypo, hyper, low rim?
Rim enhancement.
More in favor of rim enhancement.
Thank you. هاي مال الكيس القبل.
Good. Thank you very much. That's what I'm talking about. We present research. People had these patients. They did this and they did that, and the result was. So now we know that when we report an MRI with cholangiocarcinoma, we have to report not only enhancing or heterogeneously enhancing or low hypo enhancing. We have to report: is it peripheral enhancement? Is it ring enhancement? Is it diffuse enhancement? Hypo enhancement? What kind? Because according to this research, it is of prognostic importance. It is important for the prognosis of the patient.